Hello and welcome. Diabetic ketoacidosis, or DKA, is a medical emergency that requires prompt recognition and meticulous management. Whether you're a seasoned clinician or someone keen to learn, today we'll dive deep into the management of DKA, step by step, clearly and comprehensively. Let's begin with a quick recap of what DKA is. It occurs when insulin levels drop, typically in type 1 diabetes, but occasionally in type 2 during severe stress. Without insulin, glucose can't enter cells, leading to hyperglycemia. The body starts breaking down fat for energy, producing ketones as byproducts. These ketones accumulate, making the blood acidic. The result? Dehydration, acidosis, and electrolyte imbalances that can become life-threatening. 1. Initial assessment. The foundation of management. When a patient presents with DKA, the first step is recognizing the symptoms. Classic signs include polyuria, polydipsia, and dehydration, abdominal pain, nausea, and vomiting, small breathing and fruity breath due to ketones. Don't wait for laboratory confirmation if the clinical picture suggests DKA. Early intervention saves lives. Lab tests are critical for confirmation and ongoing management. Blood glucose, usually greater than 250 milligrams per deciliter. Arterial blood gas, ABG, shows metabolic acidosis with a low pH less than 7.3. Serum bicarbonate, typically less than 18 milliequivalents per liter. Ketones, positive in blood or urine. Serum electrolytes, to assess sodium, potassium, and anion gap. 2. Fluid resuscitation, reversing dehydration. Next comes fluid replacement, the cornerstone of DKA management. Most patients are significantly dehydrated, up to 6 liters of fluid deficit. Begin with 0.9%. Normal saline, 1 to 1.5 liters in the first hour. Adjust based on serum sodium. Switch to half normal saline if corrected sodium is normal or high. Once blood glucose falls below 200 milligrams per deciliter, add 5% dextrose to prevent hypoglycemia while continuing ketone clearance. 3. Insulin therapy, stopping ketone production. Insulin is essential to halt ketogenesis and reduce blood glucose. Start with a regular insulin IV bolus, 0.1 units per kilogram. Follow with a continuous infusion at 0.1 units per kilogram per hour. Monitor blood glucose hourly and adjust the rate to maintain a steady decline of 50 to 75 milligrams per deciliter per hour. Remember, insulin therapy is not just about lowering glucose. It's about suppressing ketogenesis, which is the root cause of acidosis and DKA. 4. Electrolyte management, preventing complications. DKA disrupts electrolytes, especially potassium. Even if the initial potassium level seems normal or elevated, total body potassium is depleted. Here's the protocol. If potassium is less than 3.3 milliequivalents per liter, correct potassium first before starting insulin. If potassium is 3.3 to 5.3 milliequivalents per liter, administer potassium along with fluids and insulin. If potassium is greater than 5.3 milliequivalents per liter, monitor closely but withhold supplementation initially. Also, don't forget magnesium and phosphate. Severe deficits may need correction if symptoms like muscle weakness or cardiac arrhythmias arise. 5. Monitoring progress, ensuring resolution. Monitoring is key to a safe recovery. Check. Blood glucose hourly. Electrolytes and ABG every 2 to 4 hours. Clinical signs of improvement, such as normalization of vital signs and resolution of symptoms. DKA is resolved when blood glucose less than 200 milligrams per deciliter, serum bicarbonate greater than or equal to 18 milliequivalents per liter, pH greater than 7.3, anion gap normalized. 6. Transitioning to subcutaneous insulin. Once DKA resolves and the patient is eating, transition to subcutaneous insulin. Overlap the 4th insulin infusion with the first subcutaneous dose by 1 to 2 hours to prevent rebound hyperglycemia or ketosis. 7. Addressing the underlying cause. Finally, treat the trigger. Was it an infection, missed insulin doses, or another stressor like myocardial infarction? Addressing the root cause prevents recurrence. And don't miss the opportunity to educate the patient on insulin adherence and recognizing early DKA symptoms. And there you have it, the complete approach to managing DKA in adults. Remember, DKA is a medical emergency, but with timely intervention and careful monitoring, outcomes can be life-saving. If this video clarified DKA management for you, share it with others who can benefit. Don't forget to like, subscribe, and click the bell for more life-saving medical insights. Together, let's learn, share, and improve lives.